Good afternoon, everyone. We had two wonderful panel discussions before, and I really thought that these panel discussion it was so thought provoking that we all should really are looking forward to the World Physiotherapy AWP Regional Conference 2026, which is hosted by the Indian Association of Physiotherapists. It will be held in New Delhi this year. So I'm hoping to see all of you there as well for such more discussions and more insights about how physiotherapy is evolving throughout. So, once again, good afternoon to all the wonderful panelists, our beautiful moderator, and all the distinguished guests who are present here. The discussion for today it would be highlighting the importance of staying updated, adaptable in the profession that is rapidly evolving, where integrating research, innovation, and patient-centered approaches is essential to achieving optimal outcomes and elevating the standard of care. The such platform allows us to exchange ideas, challenge the perspectives, and collectively grow as the healthcare professional. And it is my privilege to welcome all the wonderful panelists, Dr. Advita ma'am, Dr. Gopi ma'am, Dr. Komal ma'am, Dr. Heta ma'am, Dr. Krishna ma'am. And it is my privilege now to introduce Dr. Nupur Bhatt ma'am for this wonderful, insightful discussion. Ma'am is a highly accomplished academician, clinician, and a researcher, holding a PhD and MPT in musculoskeletal and sports rehabilitation, currently serving as an assistant professor, academic in charge, and HOD at Vidyadeep University. She has been shaping physiotherapists with dedication and excellence. With an impressive 11 years of total experience, including rich academic and clinical exposure, she has actively contributed to both national and international sports physiotherapy events, truly reflecting her passion towards the field. Her journey is adorned with remarkable accolades such as the Rising Star Award at 2nd IAP Women's Health Conference 2024, Clinical Excellence Award at the World Physiotherapy Congress 2023, and the Esteemed Academician Award from Jagannathan University, along with multiple recognitions from Parul University. A proud member of the esteemed bodies like the Indian Association of Physiotherapists Women's Health, Indian Institute of Sports Medicine, and Baroda Football Club, she continues to inspire through her leadership and commitment to advancing physiotherapy education and practice. With over 10 publications and a strong inclination towards research guidance, she's quietly contributing to the functional well-being of the physiotherapy profession all across India. And now I think to see yes, ma'am.
Yes, hello everyone. Good morning and good afternoon, everyone. So, today, as we are going to discuss about a third panel of our IUP, so it is my privilege to be a moderator and the host of this panel. Uh, I would like to start with my panelist. The first of all, I would like to say about the title, the enhancing the clinical reasoning skills in the physiotherapy students. So now, welcome to the panel discussions. And now, what is why this topic we have chosen, or what is the clinical reasoning? So this is the transformations of the theoretical knowledge to the effective patient care, and it is not just about knowing what to do, but it is understanding why we do, how to adopt, and when the situations are the complex or the uncertain. So that is mainly for the practical things. So today we bring together experienced educators and the clinicians to explore how the clinical reasoning can be developed, taught, assessed, and strengthened the physiotherapy educations. So now let me quickly introduce our esteemed panelist. So Dr. Advita ma'am, we welcome you. Dr. Advita ma'am is a PhD professor and the MPT guide at the Parul Institute of Physiotherapy. She has 17 years of academic experience following the MPT. She has been serving Parul Institute of Physiotherapy since April 2014 and recognized as the PhD guide. She received the Research Excellence Award in the IPWC National Conference 2025. She was honored with the Women Excellence Award at New Delhi 2023. She has contributed internationally as a resource person in the Erasmus Plus Staff Mobility Program at the Poland. She delivered sessions on the post-COVID rehabilitations at the international levels. She has 20 plus publications in the Scopus and the Web of Science journal. She has also contributed to a book, chapters, and the academic research development. We welcome you, ma'am. Next, we're having Dr. Gopi Contractor, ma'am. She is a senior lecturer and the PG guide at the Ahmedabad Institute of Medical Science. Ma'am, having the 15 plus year of experience in the physiotherapy education, she is currently pursuing PhD from the Gujarat University. She serves as the district coordinator for the IAP Women's Cell. She has published 25 plus research articles in the nationals and the international journal. She has presented research at the multiple nationals and international conferences. She has contributed as an author to books including Principles and the Practice of the Physical Rehabilitation. She holds the Government of India copyright for the questionnaires and has guided numerous research projects. She has served as a judge and a session chair at a scientific conference. She was awarded Women of Excellence in the IAPWC and the Physio Month in New Delhi 2024. We welcome you, ma'am. Next, we're having a Komal ma'am. Komal Patel ma'am is a PhD scholar and the assistant professor at the P.N. Patel College of Physiotherapy. She specializes in the community rehabilitations and is currently pursuing a PhD. She actively involved in the leadership as IAPWC Anand District Coordinator. She contributes to the community outreach and the professional development initiative. She has been recognized for her academic excellence at a national IAPWC conference. She has multiple research publications in reputed journals. She has presented her work at various national conferences. Her key interests include community rehabilitation, women health, and evidence-based practice. She focuses on the integrating research into the clinicals and the academic practice. We welcome you, ma'am. Next, we're having a Dr. Heta Patel, ma'am. She is assistant professor and the head of musculoskeletal science at Ashok and Rita Patel Institute of Physiotherapy at Changa. She specializes in a musculoskeletal and the sports physiotherapy. Her research focuses on the early knee osteoarthritis, patellofemoral disorders, preventive knee care, outcome measures, and the VR-based rehabilitation. She has received multiple awards, including IIP Significant Award in 2024 and the Women Icon Award 2024. She has also been honored with the Charusat Research Paper Award in 24 and 25 and Excellence in Research and Innovation Award 2025. She received a Special Appreciation Award at the 62nd IAP National Conference, Nashik 2025. She has authored numerous national and international publications, book, and validated Gujarati clinical tools. She is the author of guidelines for the geriatric fitness assessment and the exercise protocol and led for several funded research projects. We welcome you, ma'am.
Thank you, ma'am, for the beautiful introduction.
Next, we're having the Krishna Vyas, ma'am. Dr. Krishna is an assistant professor and the head of pediatric physiotherapy at Ashok and Rita Patel Institute, Charusat, Gujarat. She has 11 plus year experience and in physiotherapy education. Her expertise include neurorehabilitation, pediatric physiotherapy, and evidence-based practice. She is a co-author of the clinical practice guideline for the stroke rehabilitation by the Indian Association of Physiotherapy. Her research focused on the spinal cord injuries, ethics, stroke rehabilitation, autism cancer rehabilitation, and the innovative teaching methods. She serves as a co-coordinator of the research cell at Ashok and Rita Institute of Physiotherapy. She is a member of the Indian Spinal Cord Society and associated with IAP Women's Health Kheda District. She was ranked among top 500 global educators in the International Digital Teaching Olympiad 2024 and 25. She received the Dr. APJ Abdul Kalam Academician Award in 2026 for the excellence of the education. We welcome you, ma'am.
Thank you so much, ma'am, for welcoming for this session.
Okay. So this was a brief introduction of our panelists. We welcome you all. So as we are starting, let's begin with the identifying the core challenges which develop in the clinical reasoning. Now this panel we have divided into the three rounds. The round one in that the identifying the core challenges. Round two, that is the practical and the teaching strategies. And the round three is about the assessment and the innovation. So as we start with the round one, so my first question goes to the Advita ma'am. Ma'am, what is the key difference between a student who has memorized the conditions and one who truly reasoned through it? Ma'am, you're mute.
Am I audible, Nupur?
Yes, yes. Yes, ma'am.
Yes, thank you, Dr. Nupur, for inviting us in this panel. Yes, a very good question. Always in my class, regularly, I ask my student, रट्टा मारने से ज्ञान नहीं, समझ से पहचान होती है. ओके, हमेशा मैं उनको ये बोलती रहती हूँ कि रट्टा मारने से ज्ञान नहीं, Okay, so that only question you have asked me. The a student who memorize knows what, a student who reasons understands why, how, and when, and can adapt that understanding to each unique patient rather than the fitting the patient into a textbook description. You already know that we all are working as a teacher, so we know that the student who memorize knows what only. And now for making a clinical decision, it is important to learn why, how, and when. This is only the important thing for assessing and prescribing any good type of exercises. So I think this is very important. Also, we can say that a student who has memorized a condition relies on fixed facts, whereas a student who truly reason can analyze symptoms, adapt knowledge to new situations, and make clinical decision independently. So I think your questions answer will be reached to you. You are not audible, Dr.
Nupur ma'am, you
Nupur.
are on mute. Sorry. Yes, yes, yes. Okay. Okay. So as you said, the clinical decisions. But sometimes when we see jo ratta marte students, okay, though how they felt this transitions difficult.
Oh yes, transition is difficult, but I would say it is challenging. Okay, because it requires a shift from passive learning to active learning. It is very very difficult. Okay, according to our system, it is really difficult nowadays. We are adapting this active learning. Okay, so I think it would be most challenging for the teachers also. Okay, it requires shift from passive learning to active thinking, developing clinical judgment, integrating theory with practice, and gaining confidence through experience, which take time and guided exposure. Sudden change is very difficult, but most nowadays many things is changed due to AI also. Many things is easy to adapt. Okay, so I think now the scenario is going to be changed, but
So
it is
ma'am, can you
challenging.
give the one? Can you give the one example of that clinical
Yeah,
example?
many. Yes, yes. Like in the stroke, for a stroke patient, if we read the book said, the neuro books, so you can easily check. Okay, like the patient will stand up. Neuro stroke patient will stand up in 7 days. There is a 7 days protocol. Okay, but if you go in the clinical, it's very difficult. Even for the 7 months, also we are hard working for that patient. Okay, for independent work. So I think this is an exact example.
Yes, totally agree with the Advita ma'am. The student, please take a note. Whenever we are practicing theoretically, practically it's going to be a bit different. So whenever we are applying something academically or the theoretically, we need to apply practically. Passive movement आप clinic में करते हो और आपके colleagues पे करते हो, student पे करते हो. That is going to be very easy, but it is going to be difficult on patient. So totally agree with the Advita ma'am. So now I'm moving ahead with the next questions to the Gopi ma'am. Ma'am, in the early, as we have talked about clinical part, I would like to say about the early physiotherapy, mainly for the first year students, those who are learning anatomy and the physiology. So, in the early years of BPT, students are often overwhelmed with the anatomy and the physiology. So, at what stage should clinical reasoning be introduced so it cannot be seen as an only final year skill?
Hello, am I audible?
Yes, ma'am.
So first of all, I want to thank IPWC, all the authorities who has given me this opportunity and selected a very unique topic, which is actually needed nowadays. So moving towards your first question. So yes, this is a very important question because traditionally clinical reasoning is often perceived as a final year or internship skill, right? However, in physiotherapy education, clinical reasoning should ideally begin from a very first year, according to me. Then it should be developed progressively throughout the BPT program. In the early years, along with the anatomy and physiology, we can integrate a simple physiotherapy based clinical correlations. Say, for example, while teaching the quadriceps muscle. Even we can ask the students that if quadriceps are weak, what can be the functional difficulties that the patient will experience? Then student will immediately relate it to difficulty in sit to stand activities, the stair climbing activities, or gait instabilities, right? So similarly, while teaching the shoulder anatomy, we can ask that what movements will be difficult in the rotator cuff injuries. So this will encourage the student to think beyond memorization and start connecting structure to the function and function to the patient's disability, which is actually the foundation of clinical reasoning in physiotherapy, right? Then as the student will move into the second and third year BPT, we can gradually introduce some of the case-based learning, the problem-based discussions, and we can also introduce the movement analysis, right? For example, if you have a patient who is having knee pain during stair climbing activities, and then we can ask our students to think about the possible structures involved, the biomechanical factors, the muscles which are weakened, or which are the movements which will get compensated because of the following issue, right? So even at this stage, we can also introduce the clinical observational videos and simulated patients, where the student can observe the posture, the gait, different types of functional limitations. Yes, so these small steps will help them to develop the analytical thinking and the actual decision thinking, which are the key components of any of the clinical reasoning process, right? By the time when the students will reach till the internship, they will be comfortable now with the assessment planning, the problem identifications, the goal setting, and treatment progression, right? So rather than introducing clinical reasoning at a particular stage afterwards, I would say that it should be introduced early, reinforced continuously, and refined progressively. Okay, because when physiotherapy students will begin thinking clinically from day one, they don't just learn muscles and joints, they will learn to understand the movements, the functions, and patient-centered rehabilitation, which will ultimately enhance their confidence and it will prepare them to become a competent physiotherapist, right? So that is my point of view. Thank you.
Thank you so much, Gopi ma'am. So according to the ma'am, to become a competent physiotherapy, there should be a first is the consistency from the day one and from the first year of BPT. So students again take a note that anatomy is just not for your muscles and the joint. Again, we can for the movement analysis also, we have to start from the day one and the day year. Thank you so much, ma'am. Okay,
Very true.
moving
Thank you.
ahead. The questions is to Komal ma'am. Ma'am, do you, as we have discussed about the anatomy part, we have discussed about day one and the BPT first year. So now I'm asking about the examinations patterns. So do current examination pattern in Gujarat universities prioritize role in the learning over a clinical logic? Or if it is a yes, then how does that affect the student confidence in a real clinical setting?
So thank you, ma'am, for this nice question. And first of all, I thank IPWC for inviting me. And then my answer goes yes to some extent that the current exam patterns in Gujarat University focuses more on rote learning than clinical logic. Most theory exams ask repeated or predictable questions. So students tend to memorize the answers instead of understanding how to apply them in real patients. Even in practical exams, students sometimes follow steps like a checklist without thinking why they are doing it. Because of this, the effect on students' confidence is quite noticeable. That students may score good marks but feel nervous in real clinical situations. They often hesitate while taking decisions like choosing the right treatment protocols. They depend more on what they learn by heart rather than clinical thinking. So when they face real patients, they don't come with the textbook symptoms. They may feel unsure that patients, when patients come with us, they are that will be not according to the textbook. So in short, yes, rote-based exam reduce confidence in clinics. To improve this, we need more focus on case-based questions, practical reasonings, and real patient exposure. So students can think and act like clinician, not just remember the answers given in the books. So thank you, ma'am, for this.
Okay, thank you so much, Komal ma'am. So according to the ma'am, we can more focus on the practical part of the case rather than just focusing on the academic part. So we can also imply the OSPI and the OSCE in our curriculum or the examination pattern, as the many universities or the many students are not applying that. So we can go for that also, definitely, ma'am. Thank you so much, ma'am. So as we have identified our challenges, let's move to the practical strategies. So we are starting with the round two. And for that, my question goes to the Heta ma'am. Dr. Heta, we often hear about a case-based learning. So could you share a specific example of how a lecture, or for just example, any back pain or the knee pain, or can be transformed into the clinical reasoning exercise?
Thank you so much, ma'am, for the question. And once again, thank you to Advita ma'am and my entire team of IPWC Gujarat for providing me such a national platform. First, let's come to the question that I truly feel that this is where the future of physiotherapy education lies. When we speak about case-based learning, uh, we are not just changing the teaching method, we are changing the way the student learn to think, right? So let me take a simple example of a lecture on a low back pain. Traditionally, we begin our classes with the with on low back pain with a definition, causes, classification, special test, treatment protocol, right? But students and student writes a note, they memorize it, and then eventually reproduce the same in the exams. But clinical reasoning does not begin with the slides, they're not with the notes. It begins with a patient sitting in front of you. So instead of starting with the theory, I would definitely in my classes I'd begin with the story. I may say that a 42-year-old software engineer comes with a low back pain radiating to the right leg after prolonged sitting. Where do you begin? So immediately like in the room changes and students start thinking about that. What history do I need? Any numbness, any red flags, disc or muscle, mechanical or neuropathic sort of thing. So that needs to be exactly which is required at that moment when memorizing the transform into the reasoning part. Now they are no longer passive learner, right? In this generation which we are dealing with, they are Gen Z's and Gen Alpha. So in this specifically, we need to have the active learning things sort of thing. Again, they are forming an hypothesis during, if I'll put in those sort of questions, and then they will challenge them further as well. So what the sort of question I can ask in the same example: what structure is likely to involve? Which assessment test would you choose first and why? And how will you treatment change if it is radiculopathy instead of simple postural pain? So this is why it is heart of the clinical reasoning, right? Another what changes most dramatically is student engagement is most important. Instead of looking at us for a right answer, they start looking within the case for a clues, right? So they discuss, they debate, they justify, and sometimes even disagree, and honestly that is beautiful. So this is something an active learning part. And again, just a minute, just a minute.
Yes, ma'am.
Yeah. Sorry for the interruption. Yeah. So we were at like specifically the active learning sort of part, right? Another is when
when we teach students about this low back pain and all, so at that time it is difficult for us specifically to, because you have to set a simulation sort of thing. So it is, again, you don't need to emphasize on memorizing certainly. So it is thoughtful decision making, it is uncertainly as well. I often tell my students always that a good physiotherapist is not just who knows the most technique, but then who knows why this patient need this technique at this moment, right? And most of my fellow colleague also agrees to that. Again, when students start reasoning thought the real cases, something is remarkable happening, and that you can see and that you can feel. Your class is become entirely active, and they'll also waiting for your class. When the next time ma'am will again will come for the teaching. So with this, it is also for, it is motivating for us as well, and again for a student, they become confident, motivated. Even these concepts are being retained for a longer time. So most importantly, they begin to think like clinicians much earlier in their journey. So it must be start with in their earlies. We don't need to wait for till final year. So that is why it is, I strongly believe every theory lecture should eventually end in a patient case discussion, because that is where the knowledge becomes in clinical wisdom.
Okay, thank you so much, Shweta ma'am. So according to the ma'am, that is the first one is the important is the active learning. Then we can go for the case-based learning rather than starting with the just a theory. So we can start with the one case and then we can start our lecture. One more thing, ma'am has definitely said starting from what and the why. So welcome on board, little one. So from what to why we can go for. So here, ma'am already have said about the student engagement as well. So my next question is to the Krishna ma'am, that reflection is a key part of the clinical reasoning. As ma'am has already said that the motivation, the student will get motivated after a, means if you are giving the reasoning or if you are giving the case, they are interested for the next lecture as well. So here the reflection is a key part. So how can we encourage student to think about their thinking after clinical postings without it feeling like an added burden? So how it can be make interested?
Thank you so much for the question, ma'am. And firstly, I definitely thank you so much, IPWC Gujarat State team and Aditya ma'am, to provide me such a national platform and one of the panelists, so I can share my thoughts and opinion for the particular answer. So, as you asked regarding the reflection is a key point, and why the student need to think that it is not extra burden. So, for me, it's reflection is like a bridge between the experience and how they are learning. So the students often perceive that it is like extra work when we are asking them to write assessment or the assignment every time. So it is like a lengthy process. So because of the to avoid this lengthy process, we can more over focus on a thinking habit. So every time when the reflection is very much important for such a behavior. So it's not we need to integrate this is naturally into the clinical practice. It is not only one time we are asking them to have such a reflection and then the same primitive practice we are doing it every day. It's like a habit. They need to feed it into that particular. It's not additional activity or separate activity which they are doing. So for how they are doing, the first keep reflection is very much simple and structured. So whenever any therapists are treating patients or any chief physiotherapists are treating patient and students are observing the patient. So the three things, the question that comes into their mind that what did I do or what did I see? That is the observation, that is the keen observation. The second is why did I choose this particular treatment? So the behind of that treatment, what is the reason behind that? It's the same, if same conditions, the variety of treatment which we are using. So why the particular case, if the diagnosis are same, but then also the treatment protocol which we are using is different. So that comes into their mind that what is the reason behind it. And the third question which they need to ask that what will I do differently next time? So patient improvement or patient will do better or the improvement of the patient will be there. So these are the three questions they need to, each patient they need to reflect this three question each and every time. Either they need to practice with the supervisor or they need to practice with the peer groups, which like they are posted with their MPTs or they are having their physiotherapists or the tutors which they are there into the particular clinical settings. They do such kind of things. Again, regarding if after immediately class or before posting, like if they know that they need to post it in a clinical ward regarding women's health, so they need to brief about, supervisor also can brief about this kind of patient you can able to see there. So this kind of things you already know before you are practicing over there. So this kind of reflection is before only we give to the students. So definitely the clinical reasoning will be very much stronger. The one of if I case one of the example which I shared regarding the reflection is most effective if you done after immediately for the patient. So one like as the example I'm giving you stroke. So students take a stroke patient who having a right side hemiplegia. So the normal patient, when patient comes to you, they greet them and they directly started a treatment. So I asked them, why did you like directly you started with the strengthening? Why function? Why you're not thinking that functional training is more important? Then secondly, I asked that why what is the impact on your their ideal which you are choosing strengthening over the functional activity. So they don't have such answers immediately. So they think, ma'am, can I give tomorrow this kind of answer? Then again tomorrow they came and they answered. So they require such times. But if this practice happens and they prioritize what they need to do first. So before that, if we are using this in a daily basis or in a routine basis, so definitely this reflection definitely helps into that maintain their clinical reasoning. And often if this practice will be continued, the independent practice also they can do after future. So that is for my thing, that ma'am.
Thank you so much, ma'am. So, ma'am has wonderfully said that functional challenges also we should accept it rather than just focusing on the range of motions and the strengthening exercises. And just I want to say as a summary, just from to know, we should move onward to how. So it's not just limited with the to know. We need to focus on the to how as well. Thank you so much, ma'am.
Thank you.
So now, next question is to Advita, ma'am. As ma'am has already mentions about clinical reasoning process in the during the postings. Now I have also observed many times we or the senior therapist, they are just mentioning the modalities and the dosage. We are just writing and the student used to give that. So this question is like, how can we train clinical educators to mentor students reasoning processes rather than simply telling them which modalities to apply? How they can
Yeah.
decide?
Yes. Am I audible, Nupur?
Yes, ma'am.
Yes. Thank you so much. Very good question. Um, ये लाइव हो रहा है इसलिए सब देखेंगे. Okay. Clinical educator, actually they are overloaded with the work, right? Very important to update them. Okay, academicians are too much updated. Okay, but there is an always a gap between clinical and academic. That's why we arranged this whole talk and panels. Because of this only we arranged that everyone know about this. Yes, it is very necessary to update our clinical educator. Okay, they are overloaded with patient, and but they are the main persons who educate the students over the cases, right? So it is necessary. So if we can say, like, clinical educators can be trained by shifting their role from instructors to facilitators of thinking, right? This can be done by using structured questioning like why, how, what. Okay, you know, हमारा 3 साल का बच्चा है, वो कितने सारे क्वेश्चन हमसे करता है. ओके, क्यों है, कैसा है, किस लिए हुआ है. ओके, वी आर टायर्ड ऑफ गिविंग द आंसर, राइट. लेकिन वो पूछना बंद नहीं करता है, राइट. सो जब तक वो हम डेवलप नहीं कराएंगे ना, तब तक एक अच्छा प्रैक्टिकल लर्निंग हो ही नहीं सकता है. दैट इज वेरी इंपॉर्टेंट, राइट. सो एनकरेजिंग स्टूडेंट टू जस्टिफाई देयर क्लिनिकल डिसीजंस. ये नहीं कि टीचर्स कह रहा है कि हाँ इसको ओए, देन ही विल से यस पेशेंट इज सफरिंग विद ओए. Okay, it is very important to learn to answer this why, how, and what, right? And promoting case-based and reflective learning, as the Gopi madam, Heta madam, Krishna madam, Komal madam already said about this, about the clinical reasoning. It is very important that from the first year only, on case only, the students can learn the live demos. It's important. Analysis is important, not only the theory classes. I think the only 40% is theory and 60% should be the practical session is important for physiotherapists. It is necessary. Yes, clinical educators can trained by doing the workshop. Like in Gujarat only, we will focusing on the clinical practice seminars, workshops. Okay, the teachers are taking this and we arrange for everyone. Okay, it is very common in the Gujarat. So by attending the workshops on clinical reasoning, use of frameworks like hypothesis driven assessment, okay, like we use hypothesis only in the research, but I think always there we can use hypothesis driven assessment, and feedback training can further help educators guide students to think critically, right? This approach builds independence, confidence, and deeper clinical understanding instead of passive learning. So I think it is very important to train clinical educator, and also to make them change their role from instructor to facilitators.
Okay, thank you so much, ma'am. Well answered by the Advita ma'am as instructor to the facilitator. And one more thing I would like to say to all the students over here, please go for the CME workshops, webinars, even the IAP is continuously organizing the webinars on YouTube. Also, after that, you can see and you can learn by that. So there are so many things trending and coming newly day by day. So you can take a help. So the clinicians need to be involved with the academician, and the academician the same vice versa. We need to involve with the clinician as well. Thank you so much, ma'am.
Yes.
Okay, next question to the Gopi ma'am. Ma'am, as we teach to the students uncertainly and we are handling uncertainly, so when patient do not present exact like a textbook case, how we can deal with that, or how the student can deal with that?
Yes. So, yes, handling uncertainty is one of the most important aspect of clinical reasoning, because in physiotherapy practice, the patients rarely present exactly like the textbook descriptions. Okay, we see many of the patients, and the symptoms which are written in the textbook, they are not exactly similar like our patient symptoms. So if the students are trained only to recognize the ideal pattern, they may struggle when the symptoms are overlapping, the presentations are atypical, or when multiple impairments they are exist together, and usually it is the case. Therefore, we must teach our students that uncertainty is not a problem, it is a normal part of our clinical practice. To do this, we need to shift our teaching approach for finding the right answer to understanding the reasoning process. So instead of asking our students that what is the diagnosis, we can ask our students that what could be the possible causes for this particular condition, what additional assessment would you perform, or what would you do if your first treatment does not work. So these questions will help our students to develop flexibility in thinking and become a comfortable if there is uncertainty any time. Okay. So to explain this, let me share a very quick clinical example. There was one patient at our physiotherapy department who was presented with the shoulder pain while lifting the arm overhead. Okay. And many our students immediately thought that this can be the shoulder impingement syndrome, because this is the most common textbook presentation, right? But when we assess further, we found out that the patient also has a poor scapular control, one thing. There was a rounded shoulder posture. There was weakness of lower trapezius and serratus anterior. And there was some amount of instability at the cervical spine also. Now, this situation does not fit perfectly into the single textbook diagnosis, right? So the pain could be due to subacromial impingement. That can be one of the reasons. There can be scapular dyskinesia. There can be postural dysfunction, or even there can be some of the origin which is related with the cervical spine. So at this point, we should guide our students to generate multiple hypotheses together. Okay. We can perform movement analysis, the functional testing, We can try the trial interventions also, such as scapular stabilization exercise, postural correction exercise, or cervical mobilization. Okay, we can reassess and we can give a particular diagnosis to this particular patient. Okay, so this will teach our students then uncertainty should not create hesitation, but instead encourage the systemic assessment, trial, reassessment, and modification in our treatment. So ultimately, our aim should be to develop our physiotherapy students who are adaptive, analytical, and patient-centered rather than dependent only on the textbooks, right? So because in the real clinical practice, the patient, they do not read textbooks, right? And therefore, our student must learn to think, adapt, and refine their decisions. And this is truly how we enhance our clinical reasoning skills to our physiotherapy students, right?
Totally agree with you, ma'am. And I just got my one experience that the patient was having the low back pain. He went to the MRI and everything has done, physiotherapy, everything. But later, after 2 days and 1 day, it was a severe pain. Now, later on, after USG, he realized that was a kidney stone. So definitely we
Yes.
cannot rely on the textbook. We can rely on we need to adopt and we need to redefine as well. Yes. So please student, again, take a note. Textbook are for the reference, but the 60% are from the patient based and the case based learning only. Okay. So as we are moving forward, so let's focus now how we can assess and further enhance our clinical reasoning. So my next question goes to the Komal ma'am. So now again it is by from the student side for the Viva. So traditional Vivas can be the intimidating. So what alternative assessment tool? Nowadays we usually using the OSCE and the OSPI. So how have you found effective in evaluating a student thought process?
Oh, again, good question, ma'am. That and I would like to say that traditional Viva can definitely be intimidating. They often test confidence more than clinical reasoning. So we need assessment method that bring out the students' thought process, not just their memory. So in my experience, a few methods work better. That is OSCE, that is objective structure clinical examination. They are useful because they assess skill step by step in a structured way, but they include why questions, not just performance. Then again, another method is concept mapping. That is very effective to see how students connect assessment, diagnosis, and treatment. And it clearly shows their thinking pattern. Another is a reflective practice, that asking students to explain why they did these exercises, what went right or wrong, and what they would improve. This builds deeper clinical insight for the students. Then structured Viva. Instead of random questions to the students, we follow a case and ask them step by step what, why, and how. What other teachers have already said, that this reduces fear and improves clarity in the students. Then think aloud method. Ask students to speak their thought process while assessing a case. And this clearly shows their reasoning and decision making. Then mini clinical evaluation exercises. Ask them a short and real-time assessment with actual patients, and it gives immediate feedback and reflect real clinical performance on them. Case presentation, as all we academicians are doing, that students present a patient case and justify their assessment and treatment plan. And this improves both confidence in logical thinking, both in the students. Then peer learning and peer assessment. Students can learn a lot by observing and evaluating each other, and this improves clinical thinking and self-reflection in the students. Then simulation based learning. So that in that using models, which allows patient to practice without fear and harming the patients. So this is what I would like to say.
As the Komal ma'am said, There are so many methods ma'am have given. Assessment method, OSCE, skill structured, concept method, reflective practice, think aloud method for the decision making, real time questions, peer learning, peer method, stimulation based learning. Ma'am, so which one is challenging and which one is the easiest one? Komal ma'am? Ma'am, are you there? I think ma'am having a network problem. Okay. So I will take it last and I'm moving forward to the Heta ma'am. With the rise of AI and the digital health, how can technology be used to help students practice clinical decision making before working with the real patient? Ma'am, you're mute.
Thank you, ma'am. Giving this answer is actually an exciting opportunity for the professionals like us, like in healthcare educational professionals for this today's era. I genuinely believe one thing that AI and digital tools, uh, specifically the health tools, can become an simulation labs for the clinical reasoning. In my earlier example, I have given that like how from for a low back pain specific case, how we can raise the question and the curiosity in the students. So, but in this, one of the challenge we all faces is that students do not always get an exposure to enough diverse cases during the clinical posting. So there, so many times, many of them are seeing orthopedic cases, many of them are seeing a cardiopulmonary cases, and many of them are encountering the neurological cases. But not exactly in each posting, this similar pattern is not being followed, and even it is also depends on their, of course, on their interest as well. But over here the technology helps us to bridge this gap beautifully. So let's imagine giving a student an AI powered virtual stroke patient. So if we'll give in that entire scenario, the patient presentation changes depending on what student ask, assess, and even chooses as the treatment options. So now student needs to be decide which history questions matters the most. What are the immediate priorities? Again, what are the red flags cannot be missed? Which intervention is safe at this stage? And how should treatment protocols are progressing towards for the tomorrow? This is a real decision making practice and that needs to be followed. And again, the most powerful part is instant feedback. With AI, it is importantly given to the students, right? So if the student overlooks the red flags, chooses an inappropriate progression, or misses the psychological dimension, the platform immediately says the students that pause. What else should have and what are needs to be considered, rather than they are going into a wrong direction. So that immediate reflection is invaluable here. Again, because the student does not just learn the correct answer, they also learn about the specific complexity and the scenario repeatedly, even further how they are going to have it like into the clinical practice. I often compare this with the flight simulation for a pilots. Before flying a real passengers, always the pilots practice complex scenario repeatedly. Here in our practice, we always give the patients directly. So rather than giving a direct patient, we always emphasize first need to have this AI based scenario. Their student will deal with the patient and then only will ask them to deal with the real patients. So here AI allow us, even the students as well, the to make the mistakes, repeated cases, right? Even to compare the decision as well, and opportunity to refine the clinical logic. Even with this, they can build their confidence as well. So another major strength is exposure to rare and evolving the cases. So even if students never clinically sees the ICU patients, of the early mobilization, vestibular dysfunction, or complex chronic pain cases. So digital simulation can ensure the still reason through those situations. Again, however, I would like to emphasize one important point here, which is technology should never replace the clinical teacher. So it should be it should be amplify the clinical teacher. So amplify meaning you need to provide the some cues or some clues while you are teaching to the students. The real magic happens when AI stimulation is followed by guided reflection from a faculty. So faculty can give the cues like what did you choose this, why you have not chosen that another option, even what biases influence your thought process, even what alternative pathways that can exist, right? That reflective conversation is where the reasoning matures, and we can gradually from first year to final year we can gradually input giving this sort of inputs, as in reflection, and even giving this sort of question and queries to a student will definitely become good and doing good in their studies. And so, yes, I strongly believe AI gives our student a safe place to think, to fail, to reflect, to grow before they enter into real patient case scenario. So this is specifically, I can say it is a transformative.
Thank you so much, ma'am. So according to the ma'am, so nowadays we are using the VR based, we are using the robotics, and the AI reflection is a guided by the faculty should be done. So ma'am has also mentioned about the red flags. So next question is goes to the Krishna ma'am. So what is the one major red flag in the student reasoning process that indicates they are not yet ready for the independent clinical practice?
Am I audible, ma'am?
Yes, ma'am.
Okay, thank you for the question, ma'am. And yes, Hita ma'am mentioned all mainly red flags, but the one red flags which I found, and not without the using AI, which is when students demonstrate the symptoms focused thinking instead of the problem oriented reasoning. Why it is a red flag for me personally? Because in that students are treating what is visible to them, what are the symptoms visible to them, what are the signs visible to them, but why it is like limiting the patient's function properly. So they are sometimes they are not identified that properly because the lack of time, or there are so many reasons behind it. So that is one of the major red flag which I identify. So why it is looks like that is very much diminished into the practice, that is jumping directly to the treatment without identifying the primary impairment. So because they are directly just we are focusing on diagnosis, patient here, you just assess and you find that patient has some issue, so directly you go for the treatment. Example, pain is there on a shoulder joint, so directly you wanted to reduce the pain at the shoulder joint. But why it is happening on a shoulder joint? The question is not coming that mind properly, that we already discussed in the reflection also. So focusing on one symptoms while ignoring the functional impact, which I found, then inability to connect assessment findings to and treatment, which how the assessment is showcase different thing and the treatment which we are giving, that is a totally different thing. And treating impairments isolation than the complex treatment, like focusing on ADLs, they are very much lesser, those who are functioning in that properly. So why this issue is very much concerning, because physiotherapy is not just about to reducing symptoms, it is already it is always, or it is about the restoring meaningful function also. So student cannot identify what is a key problem, like limiting the patients most. Because of that only the treatment will lack direction and effectiveness. So many majority cases, if the students also have a difficulty that ma'am, I'm treating this patient 15 days, but still I'm not getting this treatment is effective. So these are the questions, but answer is not there with the students, because they have the first thing, they are not reflecting there properly. Because of that, they are finding such issue. The one I think one clinical example is if I'm giving regarding the Parkinson. So when Parkinson patient comes, of course, they have a problem regarding the tremor. So that is very much visible to them. So directly treating tremors. But in spite of patient is saying that I am having difficulty in walking, I am having freezing episodes, but they are not focusing on them. They are directly the training which we, the treatment which we focusing on the tremor reduction technique or the upper limb relaxation one, or they're focusing on rigidity. They're not focusing on the why that gait is happening, the functional limitation about it. So they are not focusing on that. So that is a red flag. So why did you choose this treatment? So sometimes students respond also. So they are directly saying the symptoms like, because ma'am, I can identify the patient is having a tremor. So I give this particular exercise to them. But they have the superficial understanding. But the prioritized of the treatment, the which treatment they need to conduct first, prioritized of the goals, they are not, they are lacking in that particular thing. So on that basis, we can say if they are not prioritizing the things like clinical judgments, we can, the independent practice has to be a little bit difficult. We are not saying we have 4.5 years of courses completely in that they are learning day by day, year by year, and semester by semester. They will definitely improve. And after 4.5 years, definitely we are giving the physiotherapy, which is very much industry ready, right? So for me, like the last statement which I wanted to quote for this particular, so when students treat symptoms without identifying the real problems, they are not giving reasoning, they are just reacting towards that particular problem. So a clinical practice demands thinkers, not just doers, that they need to do. They need to think why they are doing it. So that is just for me, ma'am.
Yes, thank you so much, Krishna ma'am. So rather than jumping directly to the treatment, we need to focus on the problem first, and we need to go towards the cause as well for the better diagnosis and the better treatment. Okay, so now we have almost done with our questions, but still I would like to brief reaction from our panelists. If or does anyone want to add any respectful challenge at the point made earlier? So already we have discussed so many points. If you want to add something on that, but it should be within a 1 or 2 sentence. Anyone?
Okay, okay,
Ma'am.
Nupur, Neeta madam is also here. So
Yes,
Neeta
ma'am.
ma'am, please, if you want to add something, so it's our pleasure.
Yes, ma'am. Neeta, ma'am.
Neeta
Yeah.
ma'am,
Good
yes
afternoon,
ma'am,
all.
please. Good
Good afternoon,
afternoon,
ma'am.
ma'am.
Yeah, I mean, I have heard nearly all the panelists. I was in between out for some time, but I think overall everyone has nearly uh, given all the aspects of
Yes,
your theme. I mean, not the theme, the panel which was to be discussed. Everything is collectively done. So extra, I don't think I have to add on, because the work which we are doing, I mean, as lastly said by Krishna, that students, they directly jump, they don't understand. I mean, the particular, if they are given a patient, they don't first give a thought for that. They just directly uh, go to treatment, I mean assessment, and they will not think like what this patient is, how we should go on. So I think you all have done very
Ma'am, your network.
Ma'am is not audible.
Neeta, ma'am.
way
Yes, ma'am.
to
There is some network issue, I think.
Ma'am,
go with the patient and do the assessment and discussion. You can hear me?
yes, ma'am.
Hello?
yes ma'am,
Yes,
yes
ma'am.
ma'am.
Hello?
Now you are
Yes,
audible.
yes.
Yeah.
Yes,
Yes, ma'am.
So, yeah. So, okay. See, this is, we say okay, we are going towards some this daily rehab programs and this, but this is the problem we always suffer. But gradually everything will be fine. But it was good panel discussions. I really enjoyed, because myself I'm refreshing everything, if I tell you, because I've been out of the clinical works, and I had been doing the some of the part of the academics, but I was out of clinical work. But I'm refreshing myself with you all people. So thank you very much for giving me this chance to learn.
thank you so much,
Okay.
ma'am. And ma'am has also mentioned about the tele rehabilitation. Thank you so much, ma'am. Okay, so
Yes.
just we can take a one or two questions from the audience, but answer should be in a one or two sentence, as we are running out of time. So, any student want to ask any question to our panelist? Student? So, may I conclude? So, I think they got everything.
Ma'am, just to add on this discussion about the student confidence, like specifically on that. So over here, I just would like to add that confidence is a deeply linked to this repeated safe reasoning practice. So here, with that point to be given, that students become anxious when they are expected to perform clinically without first being them allowed to think of uncertainty. And many a times it happens that in the classes we ask them and we always assume that they should know, but how they should know if they are not at all clinically given exposure? And if at all it is not being we are unable to give the clinical exposure, we always give them using of this AI and digital tool. So with this only we can increase their confidence as well. And another is the more exposure and the more simulation they will receive, and the even the reflective dialogue is as well. So we can give them with the use of this AI, and more naturally, and confidence can be boosted, and can the motivated, we can motivate the students. So it is not only with the one case, we have to give the repeated reflective examples to our students. So then only we can achieve that.
Okay. Yes, Aisha, you having a question? Please ask.
Yes, ma'am. So, good afternoon, all the respected panelists. Neeta, ma'am, good afternoon. Question to Komal, ma'am, was still remaining. So, I would want to hear from Komal, ma'am, the part which was remaining, her connection got lost.
Yes. Komal
I
ma'am.
think we need to repeat the question.
I think is that about clinical, we can say, assessment tool. Yes, ma'am. I agree. As we have, you have mentioned so many clinical tools, that is assessment method, OSCE, skill structure, reflective practice, think aloud method, peer learning, simulation based learning. So, which one is the most challenging, and which one is the easiest one for the student?
Okay. So I lost the connection in between.
Yes, yes,
So
yes.
my answer, yes. So linking theory to practice, that will be more easier for student than clinical decision making, prioritization. What patient needs the first, that is prioritization. कि patient को कब क्या करवाना है और कैसे करवाना है, that is more important for them. So they students know the concepts, but they cannot apply them to real cases. Another thing is especially choosing the right intervention. Students, we need to teach them that what will be the right intervention for this patient. For that we have to more focused on clinical based practice. So what to assess and what to treat first, that should be your priority. आई वुड लाइक टू से वन केस दैट टीकेआर, पेशेंट को टीकेआर करवाया है और उनका नी बाइंडिंग नहीं आ रहा है, लेकिन फर्स्ट यू हैव टू फोकस ऑन quadriceps strength rather than going for knee flex exercises. So strengthening for quadriceps is more important. If there is a lack of knee lacking, it will be there, then it will not help your knee bending also. Then explaining reasoning, they do steps but they cannot justify why they are doing. So another point is this. Thank you.
Thank you so much, Komal ma'am.
I
So,
think OSCE method even is better from student side, because we have seen that there are few checklists which is given in the OSCE, and students, at least if they will introduce themselves, if they will introduce whatever treatment they are giving to the students, they will get that particular marks to play. So I think they will get more marks if we are using this structured format. So OSCE, I think, is the more
OSCE
better
and
one.
OSCE, they both are.
Yes, both methods. They both are good and even easy.
Yes, so here I'm concluding our panel for the today, as this is for the clinical reasoning. So just I got the first sentence, रट्टा मारने से ज्ञान नहीं मिलता है. So we should focus more on the practical part. So 60% is on the practical and the case-based learning, and the 40% we can rely on the text. So we are now concluding this panel. So it was a wonderful sessions, and I think the students are going to learn. It was a fruitful. So thank you so much, our esteemed panelists. Thank you so much for the IAPWC Gujarat State and to all my seniors for giving me this chance as moderators and meeting this wonderful panelist. So we hope this discussion inspires the meaningful changes in how we can teach and we can develop clinical reasoning rather than just a classroom learning in a physiotherapy student. Thank you so much. So we are
Thank
ending
you
the
so much, all the
Thank you,
panelists.
Nupur madam.
Even
Thank you so much.
Thank you, Nupur ma'am.
thank you, Advita ma'am, being a most busiest person from our panel. She was giving her precious time for the discussions and all regarding this panel.
Yes.
Thank you,
Thank you,
ma'am.
ma'am.
Thank
so
you,
much.
respected
IIT,
Neeta ma'am,
Sales,
Thank
and
you.
Rupa ma'am.
all my
Thank you,
seniors.
everyone.